Welcome to the LSU NCBRT Preparedness Podcast. I'm your host, Ashley Markle. I'm a curriculum development specialist here at NCBRT, and I work in collaboration with subject matter experts to create valuable and timely training for the responder community. The National Center for Biomedical Research and Training provides mobile training to both the national and international emergency response community. Welcome back to the podcast. Today we're continuing our conversation with Tim about the last two problems associated with using BVMs. If you haven't already listened to part one, go ahead and check that out. We talk about the first three. And again, if you are listening to the podcast, we highly recommend switching over to our YouTube channel because this series is very visual. We're demonstrating using the BVMs and things like that. So we highly recommend that. And Tim, if you could go ahead and take it away with those last two.
Sure. So the last two things that are common problems with the BVM, and the good news is with these, you don't have to spend any extra money. You can use the current BVM, or if you looked into some of the newer versions of BVMs, like we talked about, you can do this with these two. So most people that use a BVM regularly know that one of the two big issues is the three things we already talked about, the rate being too fast, the volume, also the pressure at which you squeeze. None of that really matters if the air is leaking out the side of the mask and it's not going into the patient's airway anyway. So getting a good mask seal is really important when you're utilizing BVMs. Now, unfortunately, this skill, the mask seal, and then next we're going to talk about how to actually open up the airway. These have been mistaught for decades now. If you take a CPR course as a healthcare provider, you learn how to use the BVM, and EMT, nursing, whatever, you go over how to use the BVM. And the BVM, as I said in the last one, comes packaged in a bag like this. The mask is not on the BVM, and the BVM is squished. So when this comes out, what most people do is they open up the BVM, then they put the mask on, then they grab it like this, right? This is the EC technique, and where that came from is E, your fingers, and the C with your finger and thumb. So EC technique, and you take the bag and you put it on the face like this, and you put it on the face, and then you take these fingers and sort of squish the jaw and the mask together on one side, right? If you look, my fingers are on one side, and then open the airway, right? But what a lot of people don't realize, and anybody that spent time like in an operating room, paramedics that do their clinical time have to go to the operating room, they'll notice that anesthesiologists and nurse anesthetists don't put the mask on the BVM. They put the mask on the patient first. And how this has always been designed is to spread the mask, and hopefully the video will show this, spread the mask. Then when you put the mask on their face, and I'll just let go here, the mask kind of regains its kind of normal shape and comes in a little bit. When it does that, it's going to take in some cheek with it. So that's how you get the seal, not just putting it on. And I'll show you this, which looks a little goofy, but if I squeeze this to my face really hard, I can still move it around, right? Meaning that's not getting the best seal. Now, obviously, it helps when you put it on the nose, but if you spread, put it on the face, and then let go and move your fingers, it'll take some cheek up with it, and that'll allow the seal. So first thing first, you can change it in your practice tomorrow, but again, you have to sort of constantly practice this because it's really hard if you've been doing something for 5, 10, 25 years to just change it like that. But resist the urge to put the mask on the BVM. Just open it up and put it like that. So mask seal, that's one good way to get a mask seal. There are some other ways, little tips and tricks. For example, if somebody has a big beard or a lot of blood or vomitus or something on the face, obviously this is going to be a little more slippery. So there's a couple things you can do there. One of them, if you happen to have it, ambulances, saran wrap, food wrap used to be on the required list depending on your state. But if you took a piece of that, just a piece of that, and tore it off and then made a hole for like the nose or the mouth and nose, when you put this on the saran wrap, it grips really well. So there are some tips and tricks like that you can do if you have that equipment around. But the easiest one to fix is this. And this also is going to play a big role when I talk about the next thing, which is how to open the airway. So the next part is how to open the airway. And what we all learned was, as I said, put the BVM on the face, EC technique. So it'll look like this, or I'll sort of try to do it like this. It will look like this on the patient's face, right? And when you do that, you squeeze with these fingers, depending on how big long your fingers are. You squeeze those like that, and that puts the mask on the face. But how do we open the airway? We tilt the head, right? Head tilt, chin lift. And that's what many people have been doing forever, right? Somebody has to ventilate a patient. They go like this, they put it on, they're by themselves, they go like that, and they squeeze. And one person does it. Even though, if you ever looked at American Red Cross, American Heart Association, really any textbook, is the issue with doing that is they all say the BVM is a two-person device, meaning realistically, you should have one person holding the mask on the face really well and the other person squeezing the back. Now, obviously, if it's you and your partner and that's it, and you have to ventilate somebody and your partner has to do something else like compressions or something, then we're going to have to deal with the one person. But if there's 2 or 3 or 4 of you there, 2 people can use the BVM properly. Just a lot of people weren't taught that necessarily. So what is the setup? To get a better airway opening, we learned the head tilt chin lift. But what that actually looks like, if I turn to the side, is it looks like this. So that's a head tilt, but we're not really lifting the jaw up when we do that. So it's sort of a false term, head tilt chin lift, because really we're just tilting the head. And what we were all taught is when you tilt the head, the lower jaw and tongue and its structures and tissue come off of the airway. But you can't get that stuff off of the airway unless you're lifting the jaw, physically lifting the jaw. So many people that took CPR learned head tilt chin lift unless the patient has trauma, and then a modified jaw thrust where you put your fingers behind the angle of the jaw. So here's the angle of the jaw. You put them right here and you lift the patient's jaw up. Can't do it on somebody that's conscious, so don't try it. And you lift the jaw and it would look like this. Like that. That's now called a jaw lift, not necessarily a modified jaw thrust. And as it turns out, and you can look up different videos that are available online where they show like fluoroscopic views of sort of the patient laying there, and it kind of goes through the patient. And then when they do a head tilt, these structures are still on top of the airway, squishing it. But when you do the jaw lift, you can see a bunch of white show up here, which is the airway being open, and the fluoroscopic view can go through it. There's a bunch of those online. Um, so so realistically, every time we're ventilating somebody, we should be doing the jaw lift. But can you do the jaw lift when you're doing the EC technique? Could you kind of reach with these fingers behind the angle of the jaw and lift it? You might be able to, depending on the size of your hands. But the better way to do it is to combine the two things I just said. So first one is open up the mask like this, right? And if you notice with my thumb, I'm pressing down on my thumb and I'm opening it like this. So now when I put it on the patient, all I have to do is move my thumbs forward like this. And what you end up with, if you can see that, if I move my fingers, is now I have my thumb all the way down to my palm on either side of the BVM, almost the entire length of the BVM. That's going to get you a good seal. So you lift, put it on the face, and just slide your thumbs forward. And now what that leaves is these fingers to remember. I'm facing where the patient's on their back. These fingers can reach down behind the angle of the jaw. Sorry about all the camera movement. Behind the angle of the jaw and lift it up because the patient's on their back and lift it up. So with this way, you can spread and get a good seal, and then just move your thumbs up. Put these fingers, unless if your fingers aren't long enough, it might be these two. Behind the angle of the jaw and squeeze it. Bring the jaw to the mask, not the mask to the jaw. And that will actually open the airway better. Now, of course, that means you need two people to do that. One that's literally going to sit there and hold the mask, and the other is going to squeeze the back. I can tell you from experience, unless you are a masseuse or a rock climber, your hands are going to get tired doing this. So I find that after about a minute or so, the two people could switch. So, because obviously this person that has this job, that's not that hard. They just have to be disciplined and count to 5 or 6 or 3 or whatever they're doing and do that. So then after a minute, what I've done is switched. And the person that was squeezing then did the mask seal, right? And this technique, if you're looking for it, is called the thumbs down technique because they're pointed down towards your feet. You know, if you're on their back, it's called the thumbs down technique. And there are some variations of this. One technique that tested pretty well is to take the hand you would normally do the EC technique and still do the EC technique, but take the other hand and put it like the thumbs down and lift the jaw. Sort of a combination of those two, that works well. But the days of us just having one person on the BVM, putting the mask on like this and squeezing the jaw and tilting the head back, those days should be gone because now we know better. We have better technology that can measure that, x-rays and all kinds of stuff. And we need to get rid of those old techniques. Again, so that people don't write a bunch of comments complaining that, you know, in my service, we only get 2 people that show up because we're a call volunteer service. I get it. If you have enough people, you should absolutely do the 2-person BVM. For example, you respond to narcotic overdose or something, the patient has a pulse and a BP, but they're just not breathing. What we should be doing is the 2 people should be doing BVM, give that a good minute or 2 to get the patient's oxygenation up a little bit, then go ahead and give your Narcan or something. So we really need to change our practice, and that's really hard to do, especially when certain techniques have been ingrained in us. It's really hard to change our practice. I can tell you, and in my business, I teach mostly fire-based EMS, and I've been going through these techniques for about the past 8 years with my clients. And one day we did this in training for fifth or sixth time, and I came in the next month, and the same shift, the same battalion was on duty, and one of the people came up, and I can tell you, it was the person that I would least expect to have this conversation with, if you know that person in your organization that hates change. And this person came up to me and said, hey, we had a cardiac arrest. We did that thing with the BVM. It worked awesome. And then the medics showed up and they were like, hey, great job. Keep going. And once they did it and they tried it that first time in the patient, because it's hard to do something new the first time in a patient, now they were convinced, totally comfortable with it, and they've been doing it that way ever since. So it does work, but you have to practice it on your mannequin first. Don't just on your first cardiac arrest and you've never practiced it say, hey, I'm going to try it. The last thing I want to bring up, that when people do this technique, if this finger or this finger can't reach behind the jaw, make sure that you're not squishing them on the neck, because you can block the blood flow, hit a nerve, etc. So if what I've seen people do, if they're using these two fingers or three fingers on the jaw, and this one is just hanging out, they'll just kind of let it hang out and use these to squeeze. Don't squeeze that one on the neck, because you can work against yourself and you're decreasing blood. And those are the two things that we could fix today, tomorrow in your practice that don't cost any extra money. And again, if you're not convinced, because it's something you've been doing for, or even been teaching for 20 years, don't believe me, look up the data. I'm an instructor for a class called the Difficult Airway course. It's a 2-day airway course. This is what we teach. It's what's in the curriculum. And really, it's the better way to go to ensure that the airway's actually going to be open and you're going to get a better mouth seal.
Thank you. And I find this so fascinating. Before talking to you, I didn't know that, these were being taught so improperly. And it's especially for me, the opening the airway bit and lifting the jaw. It's just terrifying. So if these are such easily fixable mistakes, doesn't require any, new equipment or anything, why are they still being taught so incorrectly?
The question for the ages, there's probably a couple of reasons for that. One is typically in the first responder community, there's a saying, there's only two things we hate, change and things staying the same. So you kind of can't win. But I think there's a couple of reasons. If somebody was taught, let's say they went to EMT school 5 years ago, 10 years ago, and they were taught this way. And every 2 years when they recertify their CPR card, they do it this way. That's the first original thing they learned, and that stuff tends to stick with us the strongest because it was the hardest to learn. It's what you learned in your EMT or program or nursing program or whatever. It's really hard to break away from that first thing that you learned. So part of it is they've done that on patients and they feel that it worked. So they're like, well, this way is what I learned and this works. So I don't want to confuse myself by having to learn a new way, right? It's really hard for adults, or I should say it's harder for adults to learn something new and change something that's old than it is to just keep doing the old thing, right? If you're used to hanging out on the couch and watching movies, it's really hard to take that step and start getting up and going to the gym or walking or running. It's way easier to just keep sitting on the couch watching movies. So that's one reason. One reason is people don't like change. One reason is because we're working on patients, people are worried that, well, if I do this and it doesn't work, then that's going to be bad. So even though they might agree with it, when the stress comes of we have a person here that needs to be ventilated, you always go back to the first thing you learn because you don't have the confidence until, like I said with that story earlier, you do it for the first time on a patient. Then you get confidence in it and you'll be more likely to do it again. So part of it is people teach what they were taught. And if that's something right, great, because generations are learning the right thing. But if something that's maybe not right or has changed or new info came out, people keep teaching what they were taught. And 10 or 12 or 15 years later, you're like, they're still teaching that in EMT school. So I think those are the reasons why people are still being taught the wrong way.
Absolutely. Well, thank you so much for joining us on the podcast. This is such important information. Thank you so much.
Thank you very much. I had a ball, and hopefully people get something out of it.
Yes, thank you so much. If you have any questions or topic suggestions for future episodes, please send us an email at podcast@ncbrt.lsu.edu. Make sure you subscribe to the LSU NCBRT Preparedness Podcast wherever you listen to podcasts, and we'll see you again next time.